I want to thank the organizers for inviting me to speak. Tell you a little bit about myself. I lost my dad and two grandparents to lung cancer when I was 13. And then my mom and my Aunt Dee Dee died of lung cancer when I was in my 20s. In the 14 years between my dad being diagnosed with lung cancer and my mom being diagnosed, there wasn't a single advancement in lung cancer treatment, despite it being the #1 cancer killer. There also weren't any walks, support groups, or a lung cancer community at all. But thankfully, the Longevity Foundation was founded in my community in 2001, and I got involved. I did what I could to get educated and be an advocate so I didn't have to see someone else I love suffer through the cruelty of lung cancer. And while doing so, I was diagnosed with lung cancer in 2009 at 39 years old. My kids were 6, 8, 10, and 12, and their only association with the disease was death. They were scared, and my biggest fear was becoming a reality. I was following in my family's footsteps. And as you can see on this slide, there still wasn't any promising research that convinced me my path would be different. Thankfully, the treatment landscape has changed. Developments in research over the past 8 years have galvanized the community with remarkable growth in the number and variety of therapeutic options, which has led to an increase in survival and patients living much longer. But living longer doesn't mean living better. A statistical significance doesn't automatically equate to clinical significance. And that's because survival is not just some prescribed value that can be generalized. The concept of living better can only be defined by the patient and their family, because our lives are complicated. And what survival means is unique to each patient, our goals, our needs. We all come from different backgrounds, cultures, beliefs. We have family, financial, medical, logistical, and many other concerns. So the important thing here is understanding that you can't help a person if you don't understand them or know what they need. The context in which people live must be considered. Each person's cancer experience is different, and our paths are different as well. Some are linear and some are circular. So historically, people diagnosed with lung cancer didn't live long, but the trajectory of the illness has changed dramatically and will continue to improve with advancements in treatment, yet survivorship care is commonly overlooked. In fact, there isn't a standard for survivorship care delivery in lung cancer, not even in early stage setting. And the system certainly isn't built for people with advanced stage cancer. And the same is true for palliative care. It looks different everywhere. And it's not only that survivorship and palliative care don't address the needs of the advanced stage cancer survivors, there isn't a consistent, reproducible meaning across settings of all stages, and there aren't adequate resources, and it's not consistently reimbursed for anyone. So across the board, survivorship and palliative care need more standardization, quality measures, integration with oncology care, and so much more. And I want to point out that these are the fields that focus on quality of life and what is most important to patients. So they should be highly valued, but our current systems lack that. Historically, obviously, given the poor prognosis and outcomes, the goal of care for patients with advanced stage disease was primarily focused on palliation of symptoms and end-of-life care. But recognizing the growing population and limited research in this population, in May 2021, the NCI held a 2-day virtual meeting with the goals of defining the current state of advanced and metastatic cancer survivorship and research, identifying health and supportive care needs of people living with advanced and metastatic disease, and discussing gaps and opportunities for research on advanced and metastatic cancer survivorship. There is still a lot of work to be done, but it is a start. So the American Cancer Society did a survey of long-term survivors in 2015 to understand their unmet needs. And if you notice here, it did not include any lung cancer because 7 years ago, there weren't many long-term survivors. But as our population continues to grow, it is more important than ever to identify the unmet needs for patients and families, healthcare providers, and research. But many of us are living in limbo right now, and we need the support now. This slide is from a recent article published in the Journal of Clinical Oncology Special Edition on lung cancer, looking at how changes in lung cancer treatment in the era of precision medicine affect the provisions of palliative care. And as you can see, there is a lot of overlap between survivorship care and palliative care. Survivorship care and palliative care both focus on improving quality of life. And there is no one-size-fits-all approach for every patient. Let's take targeted therapy population, for example. People will be on treatment indefinitely, but now we're living 5, 10 plus years out. We don't fit neatly into one or the other. And that's where the growing overlap is, particularly with unique side effects and toxicities from newer treatments that vary from patient to patient. And with newer treatments, way too often it is assumed that the acute effects of chemo are worse than the effects of TKIs. It may look that way up front, but there is a finite time people are on toxic chemotherapy. TKIs are used over long periods of time, and the compound effects throughout a person's care is completely underestimated. So the EGFR Resisters collaborated with Longevity Foundation on Project Priority. It was a 130 question longitudinal IRB approved survey to gather information about diagnosis and treatment with a focus on quality of life. And this slide shows the most common side effects patients in our community experienced, with the green representing the severe side effects that needed urgent medical care to be managed. Diarrhea, nausea, and vomiting were among the side effects that were most severe for patients, but even some of the less severe side effects affected quality of life. I wanted to show this slide because about 63% of patients were hospitalized for a procedure related to their lung cancer or due to a symptom or side effect of treatment. They were hospitalized on the average of 2 times, and the average number of days spent in the hospital was 8 to 10. Almost all of the patients were hospitalized due to symptoms from cancer or side effects of the treatment, despite how healthy the people were otherwise. So it's important to note that while TKIs are superior to other treatments for EGFR patients, there still is a large number that experience severe side effects that require hospitalizations. One of the other questions that we asked was on mental health, and it was about depression. We found that 1 in 4 had clinical depression that was diagnosed by their doctor. Because this represents depression diagnosed by a doctor, it probably underestimates the number of lung cancer patients who actually suffer from clinical depression. Since 40 to 50% were diagnosed following their lung cancer diagnosis with a high number of suicidal thoughts, this is an area that desperately needs to be looked at more closely. And I want to highlight here why the data we collected matters. This slide compared side effect profiles between the FLORA study, which are the left two columns, and project priority in the right two columns. It's, as you can see here, that there is a striking difference between side effects in the FLORA study and project priority. And it's not surprising because nowhere in the real world are patients handpicked, closely monitored, or so well cared for as they are in clinical trials. Excuse me. So please don't ever minimize side effects. Tolerable is relative. And tolerable is more than side effects. It's about functioning and being able to do what you enjoy doing. Will you be able to work? Will you be able to maintain daily activities? These are all the things that tolerable affects in our lives. And quality of life is more than just controlling those side effects. It's being able to live while simultaneously facing new realities in many different aspects of life. As you are trying to make treatment decisions, manage side effects, continue to work, find pleasure, and enjoy life. Also, work, take care of your family, make future plans, all of the things that affect our quality of life. And all of the issues that remain with trying to figure out what survivorship looks like. How do we define it? We need to understand long-term effects, the complexity of care that is needed. There are so many issues relating to quality of life with people diagnosed with lung cancer that we haven't barely touched the tip of the iceberg. So when someone is newly diagnosed with cancer, they have to stop treatment, or they experience progression. We're confronted with making difficult treatment decisions, knowing there's no room for error, but struggling with whether the survival benefit is worth the risk of the side effects that will affect our quality of life. Our decisions are based on so many questions, such as, are the side effects temporary? Are they permanent? Can they be managed? What are the side effects of the drug I will take to manage the side effects of treatments? It's a very difficult decision that we have to make. So it's important to recognize that patient preferences are heterogeneous, just like the disease. Individual preferences vary depending on age, line of treatment, stage of cancer, what's important and meaningful to patients besides living longer. Quality of life is also unique to each patient. A young parent may be willing to tolerate severe long-term side effects to spend as much time with their young children as possible, where someone else who plays the piano and gardens wants to make sure treatment won't affect their ability to do those activities. I'm alive because of research. My dad died 3 months after he was diagnosed with lung cancer and just a few weeks before I graduated 8th grade. And my mom died 6 months after she was diagnosed and a few months before the birth of my daughter. But because of advancements in research and treatment, I have lived 13 years. I've shared so many moments and milestones with my family, ones that were stolen from my parents because they didn't have the options that I do. I am grateful that my path was different than my parents, and I appreciate every bit of it, but it hasn't come without cost. Originally, I was diagnosed with stage 1 lung cancer, and surgery was considered cured. I took erlotinib adjuvant therapy for 18 months, and I had horrible side effects. And because of that horrible experience before starting osimertinib 3 years ago, my oncologist and I discussed starting at 40 milligrams instead of 80 milligrams. We both knew 40 milligrams was probably effective, but there wasn't any data to support the efficacy. So I started on 80 milligrams, and within 8 weeks, I lost 13 pounds, horrible mouth sores down my throat, had paronychia, lacerations in my heel, and more. We reduced the dose to 40 milligrams, and I've been stable ever since. But no one should have to experience debilitating side effects that could have been avoided. Again, tolerable is relative, and now is the time to address survivorship, both early stage and advanced stage in lung cancer, and look at what a patient's quality of life is. So as research and treatment advance, so must palliative and supportive care. This is another figure from the JCO article. And as you can see in the care models, the current model is inappropriate for patients treated with some of the newer therapies who have unique needs that are different from traditional cytotoxic chemotherapy. The novel side effects, living with uncertainty, financial and logistical challenges, the ups and downs and needs change and are long-term and are very challenging. So meeting and discussing needs early on is important. Personalized medicine requires getting personal. In many places, though, palliative care is still thought of at the end of life, even though there's data to support its use throughout. So it's not just the novel aspect of newer drugs for everyone. Early palliative care helps, but it is infrequently implemented. And I would argue, especially for people with longer trajectories, because it does not feel necessary. And that is because of the outdated ideas of what palliative care does. We must change the misconception of palliative care. And I love this example of the differences between late versus early interaction with palliative care. Being proactive with support is important so that patients don't get caught in the rain without an umbrella. And I also don't want anyone to forget that stigma has a huge impact on quality of life. I recently made this poster for the American Academy of Cancer Research program I'm participating in. And it's important because words are powerful and they're important. They create perceptions that shape our beliefs, attitudes, and behaviors. So when we use words to describe and categorize people, they become labels, which can be harmful and spark judgment and biases, which then can lead to prejudice and discrimination. There is an undeniable strong blame culture in lung cancer. From media, government, and physicians down to individual, biases and stigma are so pervasive that it affects both a patient's health-seeking behavior and the physician's perception of a person with lung cancer. So we need to change the conversation surrounding lung cancer. So my key takeaways are that survival is more than a clinical trial number. It can't be quantified in a curve, and you can't quantify the unquantifiable meaning of a person's life. Tolerable is relative. Patients are the only reliable source to determine what's tolerable. Quality of life is unique to each person. A person is never done with cancer, even if they're considered cured. There will be long-term effects, emotional and physical and logistical. Survivorship care must evolve, and early intervention with palliative care makes a difference. Words matter. People matter. Using words that heal, not hurt, matters. And hope matters. It is a powerful force that lung cancer patients and our families desperately need. Hope means different things to different people, but for all of us, it is a vital emotion in the face of a lung cancer diagnosis. Hope matters. I just want to end by saying you may not save every life, but if you help your patients find their hope, I promise you will make a difference in every patient's life. Thank you for fighting with us and for us.